Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my producer, Holly, and we are streaming our midweek podcast this week from the Moses Lake Professional Pharmacy Studio. We are not on the road this week. Well, we are, but we're just still here too. So it's wonderful to be here in our studio. And today, you don't want to miss out. We have Dr. Kelsey Smith back on our podcast. We had her on, 6, 7, 8 months ago or so, before she was opening up her direct primary care practice. As you guys know, we promote a lot of direct primary care practices here all over the nation, and she's going to explain a little bit what direct primary care is, but it is a growing movement, and it is a very, very affordable non-insurance based movement. Yes, it's not insurance based and it's very affordable, more affordable, way more affordable than insurance based things. She's going to share some stories that you are not going to believe how she saved people money. Even if they do have insurance, she saves people money. So without further ado, Dr. Smith, welcome to our show.
Thanks, Shawn. It's good to be back.
Yeah. So tell us a little bit about your practice and tell us when you started and, tell us some great stories of how you've really made a difference in people's lives.
Sure. We were able to kind of launch our direct primary care practice in stages. So a lot of docs that are working within the system have to, give their 2 weeks notice, rip that Band-Aid off and jump out of one job and then, invest in this new venture and jump in, all at once. I kind of slowly eased the Band-Aid off, I guess, because I have my own private practice and have for the last 14 years where I have been a part of the system, but as a small business owner. So I have billed insurance as a part of my practice for the last 14 years. And when I decided that was something I was no longer going to do, I decided that July 1st was going to be the day that I would be outside of all my insurance contracts. So we operated in somewhat of a hybrid model for the first part of the year. I started taking pre-enrollments from patients as of, I think January 1st was when we went live with our enrollment link, and people could sign up if they knew they wanted to be a part of the direct primary care office, which for people that aren't maybe familiar who are watching this podcast for the first time or just learning about direct primary care, that's just a membership-based model where people, if they want me to be their doctor, they say that I will tell them what I think that service is worth. They decide whether that's worth their hard-earned money, and then they pay me once a month for that service, and that buys them 24/7 access to me. So they can text, they can call, they can email, they can have as many in-office visits, home visits, or telehealth visits as they need. Obviously, if somebody wants me to come by their house every afternoon and chat for an hour, that's not reasonable. But I've done plenty of home visits since starting this, and it's really a lot of fun. It liberates me to be able to do the things that you always thought you couldn't do because that's not covered by insurance, or whatever the case may be, or you're just too busy. So we started with the signups. The reception from my patients was really very good. I went into it thinking I would probably have to, argue with a lot of patients and that I might get cussed out or yelled at for changing my business model. But people were very understanding, even those that didn't feel like the direct primary care model was for them, that they didn't want to pay a monthly membership fee, could understand why I would be making a change, because I think everybody understands the shortcomings of our healthcare system. And so even those that patients that I was surprised might tell me they would rather go see somebody else, even after I felt like we'd developed a relationship over the last 14 years. Even though that was a little bit difficult to hear, there was never any harsh words or harsh feelings, and that was a surprise. So that was nice that everybody at least understood the underlying motivation for the change, and they didn't see it as a way that I was trying to gouge them for more money. I think partly in the way we presented it to them, that this was something that we needed to do for our sanity and to help feel like we were delivering an honest product.
So what was, if you just back up just a little bit, what was the motivation for the change? Why did you want to change?
We have always been a full service family practice clinic. And like I've said before, we have several doctors here in the office. Stillwater Family Care was the name of my fee-for-service practice, and with that, we had 4 family practice doctors and a pediatrician. We had delivered babies and done inpatient hospital care for our patients, as well as a busy clinic schedule. So I would deliver in a busy year close to 90 babies in a year. I would have, hospitalizations on top of that, and then approximately 25 patients per day in the office. When my partners and I decided that we were maybe getting too old for middle of the night deliveries, and they weren't interested in continuing to doing obstetrics, and even if I really wanted to continue doing it, I couldn't do it without the help of my partners to cover call. So their solution to that change, where okay, well, we're no longer going to be delivering babies, they weren't planning to go to the hospital anymore, so their plan to substitute for that lost revenue was, well, we'll just have to run faster on the hamster wheel. I remember my office manager came in and she said, okay, well, if you guys want to maintain the same level of collections from insurances and things like that, then she said, you'll just have to make room in your schedule for between 6 and 8 new patients every day. And I mean, even telling that story, I start to have a little bit of chest tightness and shortness of breath, just thinking about, okay, where am I going to find the room to put 6 to 8 more patients on my schedule per day? I've always been a little bit of the slower doctor in the office at 25 patients per day. My partners will easily see between 30 and 40 in a day. And I just never felt like I could give people the time that they deserve. Maybe I just take a little longer to process things mentally. I don't know, but it helps me to put the picture together if I can spend a little bit more time with people, and I think people deserve that. So I had been looking at direct primary care as an option for a long time. And when we decided we were making a change as a group to no longer deliver babies and that they were just going to, double down on their efforts to see more patients in the clinic, I said, you know what? That's great, but I can't do that any longer. I can't just continue to run faster. I'm going to have to figure out a way. Everybody always says work smarter, not harder. Yeah. And as doctors, we're not very good at that. We just keep working harder. So this was one solution for my own lifestyle that I thought was a way I could provide the quality of care I wanted to and be able to adjust my lifestyle so that I wasn't doing charts until midnight. That's one thing my 12-year-old son asked me when I started this. He said, Mom, once you're in direct primary care, are you going to have to be doing charts all the time at home? Because on the weekends and at night, that's what we would do. You see the patient, you get them in and out the door, do the bare minimum that you need to take care of them, but that doesn't complete the job. You have to do so much documentation for insurance that's not related to patient care that I was spending hours a night and even on the weekends to stay caught up on that documentation. And anybody that's in a fee-for-service practice will tell you that's the worst part of the job.
Yeah, I don't think any physician ever talks good about that part. And I think because of your change, I think patients probably appreciate that, because patients don't want to be working. They don't want to be seen by a burnout doctor. It's
Right.
not very fun for them. So can you explain, has that changed at all? Has your attitude changed? Has your patient's attitude changed because of this?
It has. And that's it's really kind of interesting. Even the staff here in the office, I'm not utilizing the overall office staff as much. I kept my medical assistant, and I'm still paying for my portion of our office manager, but we take our own phone calls at my desk and my medical assistant's desk. We don't really utilize the services of the front office staff anymore. I don't use the in-house biller anymore. And so I'm trying to reduce my costs that way, but we still work in the same office space as all those people. And they have commented that I'm a lot more pleasant to be around and not nearly as scary as I came across as in the past. I think because of being so harried and, stressed and burnt out, like you say, that rubs off on the people that are around you. And I even just had a random social media post recently, and a friend texted me and she said, I could just tell from your picture. She said, you just seem so at peace. She said, I don't know what you're doing. She said, but you look so happy. And I have been. It's been really great. And patients, interestingly, because they're getting more time, I think, with me, they assume that translates to less time for me. And it's a total win-win situation, because even though they're getting more of my time, my family's getting more of my time too. And it seems like an impossibility, but I actually had a patient this morning say, I love this new setup that you have, but I worry about you. She's like, how are you ever going to find time for yourself if you're giving us so much time individually? That's so far from the truth, because you interviewed Dr. Keith Smith recently, and he talked about how in a free market medical enterprise that the best situation is when you can enter into a business agreement where it is a mutually beneficial transaction. And that's exactly what I've found this to be. I mean, it's mutually beneficial to me, and not necessarily in a monetary way, but in a lifestyle and the way that I can practice medicine. And it's mutually beneficial to my patients so that they get the time they need and the attention they deserve.
Well, can you back up a little bit and talk about how I think a lot of direct primary care people that are family practice doctors that are thinking about the direct primary care model, kind of on the same subject we're talking about, they're like, wait a minute, 24/7 access to me and my cell phone, there's no way I could handle that.
Right.
But from what I've heard, a lot of times you just don't get those calls at night from these people. Is that correct?
That's exactly right, Shawn. And I was worried about that too. I mean, we've taken call as a group, forever. And I'll get those calls in the middle of the night, always have, that, well, my baby's got a fever, what do I do? What's the dose of Tylenol? Or should I take this person to the emergency room? Those types of things. But since I've changed to direct primary care, number one, I think the biggest difference is the volume of people that you are beholden to, per se, because in the fee-for-service clinic, there are 5 of us physicians. Each of us has a full practice, so estimate that at about 3,000 patients per physician that we would take care of. So that's 15,000 people that you're on call for every night that you take call. So that's a large amount of people that could potentially have an issue they need to contact you about. Since I've switched over, and I feel like I've had a really robust enrollment, I'm up to almost 400 patients enrolled.
Wow, good for you. That's awesome.
Thank you. But compare that 400 to 15,000. There's no comparison. Yeah. I mean, the percentage of people that needed to talk to me could be dramatically higher, and I would still be taking less calls. So that's really nice. And just the communication, the way that you can communicate is so much more seamless, that people can text me, and I'll often text them back while I'm in the middle of a conversation doing something else. They'll be like, hey, can I come in at 9:00 in the morning? And I'll text them back, say, yeah, that would be great. See you in the morning. And we're done.
Well, I do you think it has anything to do with, I put myself in a doctor's shoes when, if I had an emergency or I had something that needed to be done. I think when you talking back about that mutual relationship, do you think it has anything to do with one of the reasons? It could be just sheer numbers, but also, do you think it has something to do with people are like, wait a minute, this really is an emergency. I know I'm paying for this service, but I respect her time. She respects my time. It's kind of a mutual thing. So yeah. I'm just going to wait until 9:00 in the morning when she opens up. Do you think it has anything to do with that? Because people see value in something because they're paying for it. It's not completely free or covered by insurance.
I think that's part of it. And I think also because they're assured that if they call in the morning, they'll see me that day.
Oh, right.
So in the fee-for-service practice, I think a lot of times people would call after hours because they knew we were completely busy during the day. There was no way they were going to get in to see us. But that if they called after hours, they knew somebody was going to answer their call. So the whole phone tree system, where you call in and press 1 for this and 2 for that, and then you're on hold for 15 minutes, that in itself precipitates more calls after hours, because people are frustrated with the in-office system, much less their insurance system. But then, yes, I think people have a lot more respect for and the fact that I'm probably asleep at 2 a.m. Whereas because they know they're getting a hold of me. When you're part of a system, well, like my husband always said, he said when they know someone is on call, it's a blank face.
Yep.
They don't know who that person is, but they know that somebody somewhere is on call 24/7. And he said, in their mind, in that system, they just think somebody's sitting there with bated breath, waiting to answer their call, with nothing else to do. Well, if I don't call, they don't even have anything to do. And they were getting paid to be on call tonight, So in this system, people realize that it's me that they're calling and can get direct access to. And so they're much more respectful just because of that, I think, too.
So tell us, before the show, you were telling us some stories. Tell us some stories how you've already, saved some people money and
Sure.
made it really a lot more convenient because of your direct primary care practice.
It's interesting because, a lot of people will tell you the number one excuse for not signing up for a membership is, well, I have health insurance. I have to use it. If I didn't have health insurance, I would definitely sign up. And I would say there's plenty of people who have signed up in my practice who are uninsured, but the majority have insurance of some kind, but have realized that does not equate to healthcare.
Right.
Or the type of healthcare they feel like they deserve, and truthfully, they do. They deserve better than what the insurance product delivers. So, I've had people with insurance choose. Once I can lay out for them, I'm like, and you've done a good job in some of your short videos of this, but people will come in and they want a specific lab, value drawn. I was like, well, we can submit that to insurance. I don't know if it'll cover it or not. I don't know what your out-of-pocket cost will be, or if it'll apply to your deductible or co-insurance or all these different crazy, code words that the insurance, insurances use. But I can tell you, if you chose to pay cash, and the example we were talking about, somebody just wanted to have a blood count drawn, and we were checking to make sure she was no longer anemic. So I said, well, we can check your CBC for $2.50, and the blood draw fee is $3.50. So it was right at about $6 to do her blood work. And we talked about this ahead of time, and she said, yeah, that sounds great. And she paid it. And then even a couple months later, she needed some additional blood work done. And she said, I need to check up with you. She said, I'm not sure that I ever paid in full for my blood work we did before. And I looked back and I said, no, you paid. It got added to your monthly bill on your invoice, and it was $6. And she said, well, I saw that. She said, but I just couldn't believe that was the total cost for medical lab work. Everybody's always expecting those prices to be really unaffordable and inflated, and they're not. They don't have to be.
Well, isn't that same CBC at a lot of hospitals like $70?
Yeah.
I mean, crazy. And so if she would have went through insurance, best case scenario, she would have paid probably a $20 copay.
Right.
And, but maybe it wouldn't have been covered, and she would have had to pay $70.
Right.
And that's one of the things about insurance and non-transparency in the system is you don't know. So you're so much better off for routine stuff like labs and doctor services to pay up front and pay cash, because then there's no surprises at 6 months later when you get a bill for a few $100s. I mean, so kudos to you for doing that.
Yeah, awesome. It's really I don't know, rewarding to see that look of surprise on people's faces when you can tell them that they're paying so little for the things that we can get them a cash price for, whether that be imaging or medications or lab. All of that is really great. For the people that don't have insurance, obviously I always talk to them about the ways they can get some major medical backup, but some people just really aren't able to do that. And so just having a direct primary care membership in general gives them access to quality healthcare that they didn't have before. And I do have some people in my practice that are hardworking folks that just haven't been able to afford any type of insurance. And there have been some dramatic savings there, and really maybe not so much savings as just the ability to have care that they might have gone without before, or they did go without. And the instance we were talking about before the show is a lady that works as a housekeeper, known she had rheumatoid arthritis for years, but she hasn't been able to afford any medication specific for rheumatoid arthritis ever. And so she's just treated her inflammatory arthritis with over-the-counter anti-inflammatories like ibuprofen or Aleve, which is, I mean, if you were to propose that as a treatment plan for someone with rheumatoid arthritis, I think I could very well be accused of malpractice. I mean, that's not adequate care for someone with such a potentially debilitating disease. So I talked with her about whether someone had ever offered her methotrexate, and she had not. We did the basic lab work to make sure she was a candidate for that. And at a very minimal price, we can continue to check that lab work to make sure she's not having any side effects from the medication. And we're able to procure some methotrexate for her from a wholesale pharmacy and dispense that to her at a minimal cost. I think it cost her about $35 for a 3-month supply of methotrexate. And she was ecstatic that she had something that was actually helping her her joint pain for once. And she has a manual job, so to be able to continue to provide for her family, this is something that not only gives her relief from symptoms, but allows her to continue to hold down a job.
Right.
And then that same patient developed a GI virus and just gastroenteritis with stomach flu type symptoms, nausea and vomiting. She couldn't keep anything down. She was dehydrated, and her family contacted me on Memorial Day and asked, what they should do. And even, for the rote response for somebody that's in the system would be, well, you should go to urgent care or the emergency room, because that's the facilities that are available after hours or on holidays. But I happen to be in town. She's a paying customer of mine, and I was happy to meet her at the office and see what I could do. And so for her monthly membership fee, which my fees are set, she pays $85 a month. I met her at the office. I have supplies for IV fluids, and it allows me to practice medicine like a doctor again. So I was able to get her IV started myself. I didn't have anybody, no staff was there.
Yes.
So it was just me and my patient. It's just like, the way things used to be.
The old days.
With the doctor and a patient together, and the doctor not just sitting in the ivory tower, but actually doing the work themselves sometimes. And that's rewarding too, to get that IV stick on the first try is really kind of a thrill, because it's not something you have done in forever, this hands-on medicine. And gave her, I think I ended up giving her 2 liters of fluid and a shot of Phenergan, and sent her out the door, feeling much better, and saved her a emergency room visit. And had she continued to avoid care because of the potential cost, she could have ended up in the hospital, if she'd gotten too dehydrated and potentially been in, even renal failure or who knows what, that would have eventually, cost her tens of thousands if she'd ended up in the hospital. So that was really rewarding as well. A similar case is a man that he works construction and doesn't have insurance, but he's a very uncontrolled diabetic and has been for years. And he had insurance at one point. His daughter said that he had insurance. He came to see a doctor who put him on some brand name medicines for diabetes, very good medicines, but even with insurance, the cost was too high for him to afford. And so she said he told her that the reason I got insurance was to help pay for medicines. And if I still can't afford my medicine when I have insurance, there's no reason to pay for this insurance. So he let his insurance go, stopped the medicines that he couldn't afford. And so then, of course, his diabetes just got worse. I met him because he had been in the hospital with COVID. And once he got home, his family reached out to me and said, he's a mess. He's still on oxygen from being in the hospital with COVID. His blood sugars are 300. We just don't know if, he's on death's door, that something is going to get this guy. And he's not that old. I mean, he's in his 40s. So I was like, we need to help this guy. And so was able to get him generic medications for his diabetes. and make sure he was taken care of with his post-COVID type symptoms, so that his oxygen that he needed, that he could continue to have, and then was able to do lab work and things like that. I saw him back recently, and even with a good combination of cheap oral medications, his sugars are still not at goal. They're much better, but not at goal. So I was able to dispense him some samples of insulin, which is still hard to get cheaply at a cash price. But thankfully, I have good relationships with some of the pharmaceutical vendors, and could dispense him a couple months supply of insulin to get started on. So all of that, like I say, to keep somebody, not only healthy, but able to provide for their family, is incredibly rewarding. It was kind of interesting. I'm actually, one of the projects I have right now, my husband's going to help me to get an after hours pickup box for medications and things set up outside the clinic, so that when people need to pick something up because they don't get off work until after hours, can do so with a combination specific to them. They can come by and pick up whatever it is they need. And because it's been fun, but in a lot of those cases, this one in particular for the diabetic, they weren't able to come by and pick it up. And they said, well, I just don't know. We always are working while you're working. I don't know how we're ever going to pick up our medication. I said, well, I can deliver it to you. It's like, I'm looking at your address on your chart right now. I said, you live near the junior high where I'm picking up my son at 4 o'clock, after school's out. I said, I can just drop it in your mailbox if you want. And sure. So, just the little things like that, that people don't expect. And because you're working with people, like they're your neighbors, and because they are. And so, to be able to do that and drop that off and make sure he's got access to medicine, as well as just knows he can contact us if he were to ever become ill again, and potentially save his life, potentially.
Yeah. And, if you were in traditional practice like a year ago, you probably never would have offered to do that. I mean, because you are so burnt out from the day of seeing 25, 35 patients. You're like, you know what? I'm done for the day. Or you would have never started an IV a year or 2 years ago.
Right.
You're just not going to deal with that kind of stuff. And which really, in reality, I mean, like you say, it adds some flavor to your life, to your practice. I mean, it feels like you accomplished something by starting an IV, even though you might not have to as a doctor do that in some situations. It's still cool that you can.
Yeah. It does. It lends to just, the reason we went to medical school. Everybody, it sounds really corny, but we go to medical school a lot of times because we want to help people. And you don't feel like you're doing that anymore whenever you're just being shuttled from one room to the next, seeing people in 5 to 10 minute increments. They're on the schedule for 15 minutes, but you're not going to see them for that long, because you still have to document as best you can before you move on to the next person. So you don't get to know your patients as well. You don't get to do it as much hands-on type of care. That's why a lot of primary care doctors don't do procedures in their office. They don't have time. So, if you need a skin biopsy, well, we'll send you to see the dermatologist. If you need, whatever, a toenail taken off, we'll send you to see the podiatrist. Those are things we're trained to do, but we just oftentimes don't feel like we have the time to do them. And in this system, I can offer whatever procedures I feel like I enjoy doing, either as a part of my membership or at whatever honest cash price I feel like I would set for that, and then let the market determine whether that's something my patients feel like is valuable.
Well, I mean, back in the old days, family practice doctors, I remember the doctor that, delivered me in 1970. He started practicing in the 60s, small town Othello. I mean, he did appendectomies, he did C-sections, he did orthopedic surgeries.
Right.
I mean, he did eye stuff. I mean, everything. He did it all. And I think with some of these direct primary care practices, you're starting to see some of that now, where they do more things. I mean, do you have to, when you have just a simple break, and I know I'm making this sound, too generic and too simple, but when you have just a simple break in a wrist or an arm, and you just need casting, do you have to go to an orthopedic specialist if it doesn't need to be set? Probably not.
Yeah,
So
and
I mean,
oftentimes in kiddos, a very minor fracture oftentimes doesn't even need a cast, and just to monitor that, keep it splinted, and recheck an x-ray later. And that's been kind of liberating too, is, I've been in my community for such a long time. I know all the local specialists and things. I've got their numbers in my cell phone and things. And so they are wonderful, resources to send a question to. One of our local dermatologists is great. One of the cool toys I've been able to invest in since becoming in direct primary care is a dermatoscope. And that allows me to look at skin lesions in a lot greater detail, and I can take pictures of them. And so I have been sending her more pictures and saying, hey, I saw this in the office today, and what do you think? I was going to biopsy this, or do you think I should send this? Or, these are my biopsy results. Should I send this to you, or does it need to go to a Mohs surgeon? So it allows me to interact with my colleagues more. Whereas before, you might say, well, just you tell the office staff, forward these records to so-and-so, but you never have that collegial interaction. And I've been able to do that more. I have the time to reach out on patients' behalf to their specialists and things. So it's rewarding in a lot of ways I didn't anticipate, as well as the ways that I had hoped. So I couldn't be happier.
Yeah. So I want to back up just a little bit to educate our viewers and listeners. So you talked about traditional health insurance. The one guy dropped his because it was too expensive, couldn't afford anything. And I just want to say that, on our show, we've talked about health sharing ministries, health sharing programs quite often, and they are very affordable, and they are an alternative to traditional health insurance. It's what my wife and I have. My wife and I pay like $150 a month for our entire family. It's incredible, very, very affordable. And you can choose, there's many different ones out there, and you can choose the plan you want to choose at the, what you want covered. My wife and I have minimal stuff covered because we believe in taking care of ourselves, and we don't need a lot of coverage. We want catastrophic stuff. But another thing too about the insulin pricing. So on our episode number 1, my twin brother has a son that is type 1 diabetic, and I helped him navigate the system to try to find inexpensive insulin. And of course, sometimes we forget about some of the options that have been around since the 80s. And you can still, I was in South Dakota just a few weeks ago. I took a picture of it and I posted this online. Is that insulin is not always expensive. Doesn't have to be. Designer insulins, yes, but you can still get over-the-counter insulin, Humulin N, Humulin R, which 70/30, very affordable, $25 a vial. I mean, it's incredible. Don't need a prescription. And I know we could debate this for another day, but I know the designer insulins last longer and maybe work quicker, but the reality of it is those other insulins worked for years. And as a diabetic, especially type 2 diabetic, you have to watch your diet anyway. That's the most important part. So there is ways to get affordable insulin.
Well, and that's interesting that you'd mentioned that. The delivery method is something we've gotten spoiled with too. The newer insulins have, the cool little pen delivery system. And that's part what you pay for as well as the patented delivery systems that they have and things. But so while I have samples, I'm happy to give those out.
Absolutely.
To people. But you're right. It just takes a little more education to say like, okay, this is what an insulin syringe looks like. This is how you know what your dose is. You're actually going to pull up your own dose rather than click the pen.
Right.
And I don't think we give people enough credit that they can figure that kind of stuff out. People figured it out for a long time.
I agree. Right.
But it just takes a little bit more education to figure that out.
So I think you got a couple more stories. You got a lawnmower story involved where you saved a guy at a hospital visit, right?
Yeah. That's when the like I said, the communication part is so key. You never know what people are going to send me by text. I got a picture of this guy's thumb, followed by, hey, doc, do you think this needs stitches on a Saturday? He'd been trying to get something unwrapped from his lawnmower blades underneath his lawnmower and had cut his thumb open. And I said, yeah, that looks like it needs stitches. So again, there's going to be times where maybe I'm not in town, but that Saturday I was here. And so I said, just meet me up at the office. And we got it cleaned up and stitched up and sent on his way, and with, minimal interruption to my day, as well as to his. He didn't sit around waiting in an urgent care or an emergency room for hours. We just, set a time that was convenient for the two of us and got it done with, maybe 15 minutes was all it took. And like I said, I didn't charge him anything extra for that. He's a paying customer. He pays his monthly membership fee, and he went on his way and I went on mine. And, like I said, mutually beneficial. I felt like I provided him with the service that I told him I would. It was, it's always a little bit fun to do a procedure like that.
Right.
It didn't interrupt my weekend significantly, and saved him a lot of money, from and time, so that, and he, I think a lot of that too is there's a lot of trust that people place in you as their primary care doctor. So just the fact that I was the one placing the stitches, I think gives people a lot of reassurance rather than walking in and not knowing who they're going to see. Is
Right.
this person a doctor?
Yeah,
Or
right.
who is this person that might be placing their stitches? And that way, my patients always know that we have that relationship and that trust, and that helps as well.
So before the show, we were talking about sometimes when we go off into new adventures, I know we had the same experience. Some of the last people to believe in what we're doing or trust that we're going to be successful is our family. Can you talk
Right.
to that a little bit?
Well, my mom, she may watch this. I don't know. We'll find out. But her comment at one point along this venture was that she wasn't sure if there were enough independently wealthy people in my neck of the woods to make this venture work. And truly, I mean, I've got people all along the financial spectrum that have chosen this as a valuable investment of their hard-earned money, whether they are at the poverty level or if they are, considered wealthy. It's certainly not. I think a lot of times people will refer to direct primary care as concierge medicine,
Right.
and in a way it is because you're offering your services at a cash price, but we are not trying to pre-select for the very wealthy or, a CEO type practice where, you have all these executives come in for their, high price physicals or, pay you an exorbitant amount to be on retainer for them. And we really are just in, I think the direct primary care movement, the philosophy behind it and the heart behind it is that we just want to make medicine affordable again, make medicine fun to practice again, and feel like we're honest in our practice of
Yep.
medicine. I think that's one of the things that Dr. Keith Smith with the Surgery Center of Oklahoma said, he felt like an accomplice to a crime
Yep.
when you are part of a system that overcharges so significantly outside of our control. But then you are complicit in that crime as long as you continue to participate in the system. And that's been wonderful. I mean, if people don't think that my services are worth the price that I set, then that's fine. You
It's
can
great,
get
right?
somewhere else.
Yeah.
And that's the beauty of the free market. But I can set what I think my expertise is worth, and then I'm able to design my practice around that, and my patients are, I think, the beneficiaries of that.
Absolutely. And I think one of the things is that, you talked earlier on in the show about it being mutually beneficial for you and the patient. That's how a free market exchange works. But I will say this with a lot of doctors that have went into primary care, went into direct primary care, it was either they got out of medicine or they did something like you're doing. And
Right.
thank goodness that they're doing something like you're doing, because a lot of good doctors have left, and more good doctors have left medicine than went into direct primary care because it is such a racket and they just can't do it anymore. So, kudos to the doctors like you that are doing this so you can still take care of people, and they can have good doctors.
Yeah. I mean, it is because there's so many people that even if they're still, in medicine, they may have chosen to do a completely administrative job,
Right.
or things like that because they feel like the practice of medicine is not possible to do, the way they want to. And that's what I would say to people who are on the fence or who feel really burnt out. I mean, I really do love my job again. I don't think I ever got to the point where I hated coming to work, but there were aspects of my job that I really disliked. And I've been able to minimize that percentage of my job just by tenfold. I mean, dramatically decrease the tasks that I have to do on a daily basis that I really just abhor are minuscule now. I mean, there's very little about my day that I dislike or that I you know don't look forward to. I mean, I look forward to coming to work again.
Yeah. Well, I love it. And, I'm going to have to go back and watch our episode from a few months ago.
Sure.
But I can honestly tell, Dr. Smith, that you do look and talk different than you did before you started this practice. I'm serious. You just seem so vibrant, so happy, so calm. And
Right.
I love it. I love it. So it's obviously that you have a passion for what you're doing and you're enjoying it. So thank you so much.
Absolutely.
So as we wrap this podcast up, how do people get a hold of you if they have questions about direct primary care?
I think that's one of the best parts of this. I mean, I can give people the number that reaches us directly. There's no middleman. So our phone number that comes directly to my office during office hours and to my cell phone after hours is 405-777-4955. And I'm happy to put that out there for anybody to call that wants to talk to me or chat about direct primary care. Our website is www.pioneerhealthdpc.com. And like I said, I'm not opposed to talking about our system with anybody that has questions.
Awesome. I love it, Dr. Smith. Thank you so much for being on. You definitely achieved our goal of educating and empowering consumers to take charge of their own health. So thank you so much.
Oh, you're welcome. Thank you, Shawn.
So Monday, tune in to Health Solutions with Shawn and Janet Needham. We will have Lori Powell on for her second interview where she talks about her a journey of health, and the second part of it is her recovery from addiction. So you don't want to miss out on that. 12:30 to 1:30 Monday, Lori Powell about her addiction recovery. So tune in to Health Solutions with Shawn and Janet Needham. Thank you so much for watching.